Thanks, Angie. Welcome, everybody. I have a lot to go over, so let's just dive right in. Today, I'm going to give you an update on all of the new information that we've learned in the past year or so about the risks and benefits of hormone replacement for menopausal patients. A lot of the risks that we've been worrying about for decades that prevented a lot of patients from adequately treating their menopause symptoms have been reevaluated, and now we have a new perspective. So all of the pharmaceutical labels, medical societies, doctors' recommendations on hormones, warnings, this all was based on the results of the Women's Health Initiative in the early 2000s. This was a large trial that we have since reevaluated and found a completely different conclusion. So we'll go over that. And we're also going to talk about risks and benefits of continuing hormones into older age. And we'll talk about a new non-hormonal hot flash medication that came out last year. So in case these terms are new to you, just to kind of go over the abbreviations and things I'll be using, progestogen is hormones that can bind progesterone receptors. That includes our own endogenous progesterone and the bioidentical equivalent, and also synthetic progestins that are molecularly dissimilar to progesterone. Bioidentical and isomolecular mean the same thing. Sometimes the conventional medical community uses the word bioidentical to imply that the hormones are compounded, but that's not technically true. MHT means menopausal hormone therapy. It could be bioidentical or otherwise. HRT usually means it's not. CEE means estrogen made from horse urine. And then MPA is medroxyprogesterone acetate, a common progestin used in birth control, and also conventional HRT. Okay, hopefully that's all clear. Let's go back to the beginning, back in 1998, or at least I'll call it the beginning. This was the WHI, the Women's Health Initiative, a study that wanted to look at the effects of hormones on cancer, cardiovascular disease, and osteoporosis. And they gave CEE with or without medroxyprogesterone acetate to a large number of postmenopausal females, and they compared this to placebo. They had to stop the combination hormone trial early in 2002 because the women in this in the drug group had an increased risk of coronary heart disease and breast cancer initially. They also were finding a reduction in fractures from osteoporosis and a reduction in colorectal cancer. The conjugated equine estrogens only trial stopped 2 years later in 2004 because they had a small increased incidence of ischemic stroke in the HRT group. These results made major headlines in mainstream media, and they concluded that the risks of HRT outweighed the benefits, and patients and doctors started fearing hormones. People stopped asking for them. Doctors stopped prescribing them. The WHI had major flaws and limitations. It only studied oral horse estrogen and medroxyprogesterone. And so the results can't be extrapolated to other formulations and also to non-oral estrogens. Statistical significance was being questioned early on, way back in 2004, because almost half of the participants dropped out of the study early. And a reanalysis that year found no increased incidence of coronary disease. In 2018, it was discovered that a large proportion of the placebo group had previously used estrogen. And so taking the previous estrogen users out of the placebo group led to a new conclusion that the conjugated equine estrogens plus MPA did not have an effect on the incidence of breast cancer. So this is big news. Hopefully people are finding out about this now. Another thing to know is that most of the participants in this trial were 10 years or more past the point of menopause. And the results in this trial were conflicting with earlier studies that involved younger women, meaning under age 60 or within 10 years of menopause. And so age stratifying the results of the WHI found that the younger users who were within 10 years of menopause had slower growth of calcification in their arteries than placebo, and they had reduced cardiovascular risk and reduced all-cause mortality. And so the timing hypothesis was suggested because of this, that starting hormones earlier on provides more cardiovascular benefits and perhaps less harm than starting hormones too late. After 18 years of follow-up, an observational study looked at these results again and concluded that postmenopausal hormone therapy was not associated with all-cause mortality, cardiovascular, or cancer mortality. And we actually found that there was a decreased risk of getting breast cancer for the next 20 years in women on estrogens alone. They also had reduced ovarian, uterine, and lung and colorectal cancer, as well as breast cancer mortality. These relative risks are pretty big, but because the number of events in this group of women was pretty small, the absolute risk reduction, meaning what percentage the risk went down by, was really modest. So it was less than 1% reduced risk of incidence of breast cancer. So you would need to treat 128 women for 20 years to prevent one case of breast cancer. Similar risk reduction as far as preventing breast cancer death. But the moral of the story here is that the estrogen was not increasing risk of breast cancer. And so history of breast cancer is officially a contraindication to estrogen therapy because it's thought that it increases recurrence. In the 1940s through the 1970s, high-dose estrogen was actually successfully used to treat metastatic breast cancer. I'm showing you this book cover written by Avram Blooming because he is a contemporary oncologist who uses estrogen for breast cancer survivors. And he compared 248 of his patients using Premarin to case control patients not on hormones. And he found that the patients on estrogens had no increased risk of recurrence 14 years later. HRT in breast cancer survivors is generally contraindicated because of the results of the HABITS trial. The Stockholm trial was a similar trial that was done at the same time, but they used different types of progestins and had different results. So the HABITS trial used norethisterone. Stockholm trial used medroxyprogesterone acetate. Norethisterone has been shown in other studies to increase the risk of breast cancer more than other progestins. And the HABITS trial unfortunately found increased local or contralateral recurrence in the patients who were on estrogen plus norethisterone. And they had to stop that trial after 2 years. They didn't find any increase in recurrence for those who are just on estradiol or conjugated equine estrogens. And follow-up in 2008 found no increase in mortality. They also didn't require any baseline breast imaging like a mammogram prior to entry. So it was a poorly designed, poorly controlled study. There were members of the placebo group who were on hormones. There were members of the hormone group that were not on hormones. So this trial was kind of a mess. And this is the main reason why we are avoiding giving hormones to women with a breast cancer history. Vaginal estrogen has been associated with 20% fewer cases of breast cancer recurrence versus no hormones. And recurrence is lower among vaginal estrogen users compared to oral estrogen users. These therapies are contraindicated if patients are on aromatase inhibitors because adding estrogen counteracts the effect of the medication. So back to Avram Blooming. In 2022, he published a review of 25 studies of breast cancer survivors who were given HRT, and 17 of them that are listed here included patients who had positive estrogen receptor assays. None of these reports, except for the HABITS trial, identified an increased risk of breast cancer recurrence, and 5 of the studies reported fewer breast cancer events among the survivors giving HRT, and then 4 of them had reduced mortality from breast cancer. All right, so now that we are done going over all those studies, we're going to go into the evolving conventional opinions on hormone therapy. And all of the major kind of guiding bodies have been updating their opinions lately. So I'm going to start with ACOG back in 2021. They noted that it is okay to take vaginal estrogen for patients with a breast cancer history after a trial of non-hormonal options if they need it for vaginal symptoms. It can be used at the same time as tamoxifen, but for patients on aromatase inhibitors, they have to consult their oncologist. These are the non-hormonal therapies and dosages. Hormones do work better for maintaining tissue integrity, decreasing dryness and pain with intercourse, and these non-hormonal therapies don't decrease risk of breast cancer recurrence. These are some non-estrogen hormone options: vaginal DHEA, vaginal testosterone. There's also ospemifene, which is an estrogen receptor modulator. It causes hot flashes and night sweats, though. So I've never used it for any patients. Kind of curious if any of you have prescribed it. Now I'm going to move on to the North American Menopause Society in 2022. This is a list of contraindications. Just for your reference, you can come back to this slide. But notice that family history of breast cancer is not a contraindication to hormone therapy. And also, BRCA1 mutation is not an absolute contraindication if patients have had removal of their uterus and ovaries. Okay, more from this position statement. They are mentioning that hormone therapy is the most effective treatment for vasomotor symptoms and genitourinary syndrome of menopause, and it also prevents bone loss and fracture. Breast cancer survivors who have severe vasomotor symptoms not responsive to other therapies might be offered systemic hormone therapy if their oncologist has been involved in the decision. This is supposed to be a rare exception. If they have vaginal symptoms, they may be offered vaginal estrogen or DHEA if approved by their oncologist and non-hormonal options didn't work. These are the non-hormonal treatments for hot flashes with the best evidence. Paroxetine is the only SSRI that's FDA approved for hot flashes, although when I tried to prescribe it, the 7.5 milligram dose was not available at the pharmacy and I had to prescribe 10 milligrams. I haven't seen it work. Results from 6 randomized trials showed that 79% of the mean treatment response for hot flash frequency is placebo response, meaning the true drug effect is only 21%. There is a new medication. It's the last bullet point there, fezolinetant. It's also called Veozah. It acts on the hypothalamus, and it's significantly more effective than antidepressants. But you do have to check liver enzymes really often because liver damage has happened in a few people on this medication. And here's another new development. There was an FDA expert panel, and they called for removing the black box warning from estrogen, and they argued that these warnings discourage women from pursuing effective menopause treatment and osteoporosis treatment. This hasn't changed yet, but I think this is going to happen. Okay, so next, everybody wants to know, is it okay to start hormones after age 60? Or at least a lot of people came in with this question prior to me starting this webinar. And the reason we're worried about starting hormones late is because we wonder, is it going to increase cardiovascular or cognitive risk? So regarding cardiovascular risk, it's recommended to calculate a patient's baseline atherosclerotic cardiovascular disease risk score. You can find these calculators online. It asks you questions and tells you their risk of having an event. So if that risk is under 5%, then systemic hormones may be acceptable, and systemic includes either oral or topical or patch hormones. Note that vaginal estradiol is not considered systemic, so that is not contraindicated regardless of these risk scores. Okay. Starting oral conjugated equine estrogens with or without a progestin can promote or worsen dementia in this age group. But Low-dose transdermal estradiol patches did not affect cognitive function in women in their 60s through 80s, and it also can improve bone density. There also was a meta-analysis involving 30 randomized studies, and they included all types and routes of estrogens with or without a progestogen, and they didn't find significant effects of late initiation on cognitive domain scores. So that's what we have from mostly randomized trials. As far as observational evidence, bioidentical formulations that are initiated early and continued for 6 or more years have been associated with decreased risk of dementia. Oral medroxyprogesterone acetate may antagonize the effects of estrogen on brain regions that are involved in memory, like the hippocampus. Vaginal estradiol has not been shown to increase risk of Alzheimer's regarding timing of initiation. So in both cases, whether you're thinking about risk of dementia, cognitive decline, or risk of cardiovascular events, vaginal estradiol seems to be the best choice here to minimize those risks if it's someone who hasn't started hormones by age 60. In 2024, we also finally got some answers about the safety of continuing hormones past age 65. It used to be common practice to just stop if they've been on hormones for 10 years or stop if they reached age 60 or 65. But now we have this really large trial, and they were looking at records of 10 million Medicare women who were over 65, and they concluded that women in this age group can safely continue taking hormone therapy because, compared with never using hormones or discontinuing them earlier, the use of estrogen alone beyond this age was associated with significant risk reductions for mortality, certain cancers, heart failure, DVT, AFib, heart attack, dementia, and as far as the death incidence, twice as many people died in this cohort who were not on hormones versus those who were on hormones. So it was 6.3 versus 12.6 deaths per 1,000 person years. So that's pretty significant. And here are the details from this study that I found most interesting. You can follow that link for the full text if you want to read more on this, but here's what I noted, that progestins with estrogen reduced other important risks that I listed here. Progesterone with estrogen reduced the risk only of congestive heart failure. What else? Okay, routes and formulations. Topical and vaginal estrogens significantly reduced the risk of stroke and dementia, and mortality was reduced more by bioidentical estradiol versus conjugated equine estrogens. Progestin monotherapy increased breast cancer risk by 21%. Progesterone alone decreased breast cancer risk by 10%. And the study concluded that the safest hormones were low-dose vaginal or transdermal estradiol, and adding a progestogen doesn't increase any of the risks as long as these rules for what type of estrogen you're using were followed. And the other big news from last year was that after 20 years of follow-up with the WHI, they found that ovarian cancer incidence and mortality more than doubled among women who are on estrogen alone, and this difference reached significance after 12 years of follow-up. So women on combined therapy didn't have increased risk of ovarian cancer. Progestogens or progesterone is not just necessary for endometrial protection. It has many other functions. It affects brain health. It affects bone health. It protects the ovaries. So there are plenty of other reasons to include progesterone, even if a patient has had a hysterectomy. Okay, we've been touching on this a lot in the talk so far, but now there's this official announcement that ACOG made in 2024, updating their perspective on the safety and risks of bioidentical versus non-bioidentical hormones. And so conjugated equine estrogens, they mainly bind to beta receptors, and this increases inflammatory markers. It contributes to collagen breakdown, promotes plaque destabilization, and cardiovascular events. Estradiol binds to alpha and beta estrogen receptors, and transdermal forms have been shown to improve hot flashes, vaginal dryness, and increase bone density. Progestins can bind to androgen and glucocorticoid receptors. They can promote insulin resistance and increase breast cancer risk. Medroxyprogesterone increases the risk of thrombosis, but micronized progesterone has not been implicated in these risks. And then also ACOG finally acknowledged the reevaluation of the WHI that happened 6 years prior that we already talked about. And so that was all about the risk of getting breast cancer. The risk of dying from it has been shown to decrease with estradiol plus or minus a progestogen. And this was from the nationwide Finnish comparative study in 2016, using these hormones for up to 10 years, was associated with decreased risk. Mortality was reduced by 50% among all age groups, even when synthetic progestin was included. And so now we have all that data to help us choose the lowest risk forms of hormone supplementation. So I'll go over prescribing options. First thing to know, I would always choose transdermal estrogen. Oral hormones, even if it's oral estradiol, still, it's been shown to increase the risk of DVT, having to have a cholecystectomy, and ischemic stroke. The reason that oral estrogen is harmful is because these are processed in the liver. They lead to supraphysiologic concentrations and formation of harmful proteins that cause these effects. Okay, so these are conventional low-dose vaginal estradiol options. I listed the daily doses in micrograms. These are isomolecular, bioidentical, and they might be covered by insurance, one would hope. If you're using a vaginal tablet or insert for your patient, they're going to do that once a day for 2 weeks, followed by one insert twice weekly. If they choose the vaginal ring, they insert it and replace it after 90 days. These are more medium doses. That might be more appropriate for more recently postmenopausal patients, or if you need higher doses to deal with symptoms. The Fem ring comes in a more moderate dose. The instructions are the same as for the S string. And then vaginal cream is also an option with instructions there. That's what the package insert will explain. And there are some hormones that are available without a prescription. These are vaginal suppositories that you can find. They contain a combination of one or all or two of estriol, DHEA, and progesterone. And estriol is great to include because it's specific to estrogen receptors in the vaginal tissue. It's great for treating vaginal dryness. And the dosing instructions are the same as for the vaginal tablets or the creams. Just warn your patients that these are going to melt and they can stain clothing, so they need to use a liner to prevent that. These are the conventional low-dose estradiol patches that are available. They're going to be specific to whether the patient is to use them once or twice per week because they're formulated to last a specific amount of time. And patients apply them to the lower abdomen or the upper buttock, and they can rotate sites. I really like patches because they're very effective for hot flashes and night sweats because they deliver hormones very steadily. And they're not as messy as creams, so that might be a benefit for some people. Prometrium is a brand name for micronized progesterone. It is bioidentical and it's standardly available in 100 milligram or 200 milligram capsules. It does contain peanut, so for patients who are allergic, you need to compound their progesterone. In my practice, I like oral progesterone to help for sleep or anxiety because it metabolizes to allopregnanolone and that stimulates GABA receptors. I also like to use topical progesterone, which doesn't have the same level of evidence for endometrial protection as oral progesterone. The studies that are available were smaller and shorter duration, but I listed the best studies we have here just so you can see. The key to endometrial protection is using an adequate dose of progesterone, regardless of the route that you choose. There's also some evidence that transdermal progesterone is protective of the breast, so I listed that here. One study had women apply 25 milligrams of progesterone to their breasts as they waited for biopsy for benign lesions, and the treatment was shown to decrease cell proliferation. Dosing, if you're using transdermal creams, is based on body weight. 40 to 60 milligrams is a good dose if they weigh 150 pounds or more. If they weigh less than that, you can start with half the dose. If they have more severe hot flashes or mood symptoms, you might think about splitting the dose in half and delivering it twice per day. If you're compounding your hormones, you can mix them all together, although I would say don't put DHEA in the cream, which I'll talk about in a minute. We've noticed that DHEA might cause some competition for absorption with other hormones. So I like to use oral DHEA. When I use hormone creams, I like to give biased rather than just estradiol because estradiol binds with beta receptors in vaginal endothelium. Estradiol binds with both alpha and beta receptors. So estradiol is it's mainly not binding with receptors in the breast tissue or the endometrium and can't cause proliferation there. It doesn't convert to harmful estrogen metabolites. It's anti-inflammatory. It has anti-carcinogenic effects. So there are a lot of reasons to include it. It can help decrease the dose of estradiol that you need to use. Androgen. So when you're replacing hormones for perimenopausal or postmenopausal females, you might need to include testosterone or DHEA. You can test their salivary hormones to find out if they're deficient in these hormones. These are going to be helpful for things like energy, cognitive function, libido, bone health, mood. And so if you use testosterone, you're going to have to compound it because there isn't an FDA approved option for women. And I tend not to go above 1.5 milligrams per day. If you are using too much or if they're metabolizing it too much down the 5-alpha reductase pathway, which you can check if you do urine metabolite testing with a HUMAP, then it can cause symptoms like unwanted facial hair growth, scalp hair loss. So watch out for that. Think about testing to see if you need to add some treatment to downregulate 5-alpha reductase, or you might need to reduce your dose. DHEA oral doses for females, 2 to 10 milligrams tends to be good for them. Okay. Beyond choosing the lowest risk types of hormone therapy and kind of selectively choosing who's going to get hormones, we can be proactive about supporting the body's ability to metabolize and detoxify hormones down safer pathways with lower risk of hormone side effects or hormone-driven cancers. So we're going to go over how to test hormones and metabolites in urine and how to use this test to help decrease risk by supporting safe metabolism. So in urine, as far as assessing estrogen metabolism, you can look at levels of unconjugated estrogens like estradiol, estrone, estriol. You can evaluate phase 1 and 2 detoxification in the liver. You can make some conclusions about phase 3 detoxification is when hormones leave the body. Problems you want to watch out for would be too much 4-hydroxylation, insufficient methylation, and problems with digestion, especially constipation and dysbiosis, because these can lead to excessive hormone recirculation. Estrogen metabolism is primarily happening in the liver, and phase 1 is hydroxylation. This makes the fat-soluble estrogens a little bit more water-soluble. Phase 1 is also transforming antibiotics, pharmaceuticals, xenobiotics, and if these intermediary metabolites are not excreted from the body efficiently, they can damage tissue and DNA. We'll go into that a little bit more. Of the phase 1 estrogen metabolites, 2-hydroxy is seen as safer or less estrogenic, and then 4 and 16 hydroxyestrone are thought to be more estrogenic, proliferative, and have more potential to cause DNA damage and increase risk of breast and prostate cancer. So if you look at these gray bars here, this is showing you the percentages of 2, 4, and 16 hydroxyestrone. Between the dotted lines is where you want it. In this example, this person is 4-hydroxylating too much. You can also look at the 4:2 ratio and the 2:16 ratio. You want to favor 2-hydroxylation for both of those. Usually we're going to try to increase the CYP1A1 enzyme's activity. This is the one responsible for 2-hydroxylation, and it's going to ferry estrogen down this safer pathway. Toxins that move through this system are temporarily more dangerous and possibly carcinogenic intermediates. So after this, they do need to continue through phase 2 and phase 3 to be inactivated and leave the body. If you want to know how to read this image, each of these circles is a different metabolite. So this one is 2-hydroxyestrone. You can watch it get methylated down here to 2-methoxyestrone. Okay, to upregulate CYP1A1, you can do things like cruciferous vegetables, DIM, which is from broccoli, fish oil, rosemary. You also might think about why there's not enough CYP1A1 activity. So, think about things that can slow it down if that's a lifestyle like smoking, charred meat. You also might need to slow it down if phase 2 is also slow, so you don't end up with too many intermediary metabolites. Don't worry if your patient is eating berries. I wouldn't tell them to quit. I would just, if you want to promote CYP1A1, just focus on promoting it and don't use any concentrated nutraceuticals that would be downregulated if you can avoid it. So almost every time I've looked at these reports before and after for patients on DIM, in probably every single case except for maybe one, the DIM is improving this 4:2 ratio. So yellow means it's upper range, so a little bit too much 4-hydroxylation. 6 months later, this patient's ratio is optimal. And the percentage of 4-hydroxyestrone went from high to optimal. Optimal is this dark gray zone here. CYP1B1 is the enzyme that 4-hydroxylates the estrogens. 1B1 is more prevalent in tumor tissues. It increases fat uptake. It's associated with metabolic syndrome. It also has beneficial functions. It can protect from some other kinds of cancers. Mice that don't have CYP1B1 have more lung tumors. It's also involved in eye development. So we don't want to be completely missing the enzyme, but we just don't want to have too much of its activity. And the other thing is, think about lifestyle, because things that upregulate CYP1B1 are inflammation, insulin resistance, toxin exposure. So think about that. If you see too much activity, look at lifestyle. And then also think about pushing 2-hydroxylation or maybe something like rosemary. CYP3A4 converts estradiol to estriol and then estrone to 16-hydroxyestrone. It also deactivates testosterone. It metabolizes carcinogens and caffeine. 3A4 is upregulated by St. John's wort, capsaicin, valerian, and so on. We also see higher activity in females, people who smoke, who have diabetes. Iron and vitamin D are cofactors that it needs. So if someone has a deficiency, this might slow this enzyme's activity. Okay. The phase 1 estrogens, especially 4-hydroxyestrone, can potentially convert to quinones and semiquinones. These are highly reactive molecules. They can form reactive oxygen species. They can bind to and damage DNA. Methylation renders the harmful 4-hydroxy metabolite significantly less active. Glucuronidation and glutathione conjugation are 2 other phase 2 liver detoxification pathways that are important for hormone metabolism. So if we're looking at this, there's more likelihood for 4-hydroxy estrogens to form reactive oxygen species if we have too much 1B1 activity, if there's an MTHFR problem or B vitamin deficiency, because this is responsible for giving a methyl group to the COMT. You can also have a variant in COMT. If COMT is too slow, then these are going to go down this pathway, form quinones and semiquinones, and possibly attach to DNA. Your last chance is the glutathione sulfotransferases, and I'll show you how to support those. There's also quinone reductase, which reduces this. If you want to know if you have a problem with phase 2, look at the methylation potential. So you're going to compare the levels of methylated estrogens to their corresponding hydroxylated estrogens. The higher the methylation ratio, the smaller the potential to form the reactive quinones. And it's important to look at methylation both on the 2 side and on the 4 side, because this is not always going to be the same. And I've only seen the capability of measuring the 4-methoxyestrone in labs that use liquid urine. Here are some options to support phase 2. You can think of support for MTHFR, like your methylated B vitamins, pyridoxal 5-phosphate, which is activated B6. You can give SAMe, which is the methyl donor for COMT. Magnesium is the cofactor. And then if you want to support those glutathione sulfotransferases, there's a list of foods here: rosemary, rooibos, and then sulforaphane and resveratrol directly reduce the quinones. And the other thing is, always think about the cause. So if COMT is slow, think about why it's slow. This is why lifestyle is really important in supporting proper hormone metabolism and in just general hormonal health. You need proper sleep. You need to think about sugar in the diet, inflammation, using the wrong kind of estrogen, like conjugated equine estrogen, too many medications, too much stress. All of these slow down COMT. And so we already talked about how phase 1 estrogens can form DNA adducts. So the formation of estrogen DNA adducts has been found in people who have several types of cancer, but it's also been seen in people who have a high risk of breast cancer. And this is showing us that the formation of the adducts is along the pathway to cancer initiation. All right, this is showing you how supplementation with N-acetylcysteine and resveratrol can help prevent adduct formation. So these are the estrogen DNA adducts. This is phase 1 metabolism of the estrogens. Resveratrol slows this down. N-acetylcysteine blocked the adduct formation. And then both of these ferry these intermediates towards safe pathways of deactivation and elimination, like COMT and the glutathione sulfotransferases. The next phase of estrogen metabolism is phase 3. That's when the breakdown products are leaving the body through urine or stool. So you want to think about proper diet, proper gut health. Is the person eliminating every day? Are they hydrated? So these things are important. The estrobolome is a microbiome of colonic bacteria that induce estrogen metabolism via this enzyme beta-glucuronidase. This enzyme can deconjugate the estrogens and allow them to reabsorb. A healthy microbiome that has adequate abundance and diversity can ensure fecal excretion of conjugated estrogens. On the other hand, if you have a really unhealthy diet and lots of toxin exposure, then you might end up with excessive deconjugation and too much estrogen recirculation. And clues that you would need to support phase 3 can be pretty obvious. So if someone is constipated, if they have dysbiosis, if their diet is really unhealthy, also if you see high estrogens or high androgens and there's not a simpler explanation. You can test stool to look at beta-glucuronidase activity. And if it's high, then think about soluble fiber like Jerusalem artichokes, oats. Eat 30 different plant foods per week at least, because that promotes gut microbiome diversity. Calcium D-glucarate can help bind and eliminate excess estrogen, and it can decrease beta-glucuronidase activity. And then lifestyle-wise, think about not too much alcohol, not too much stress, not too much sugar. 8-hydroxy-2-deoxyguanosine is not an estrogen metabolite, but it is a marker of oxidative damage, and it can help you identify or confirm damage from quinones and DNA adducts. There are also many conditions, and they're common, that are associated with oxidative stress, like psychosocial stress, inflammation, insomnia, hypertension, depression. So if you know the cause of oxidative stress, definitely address the cause. You can also incorporate helpful nutrients like melatonin, green tea, garlic, fish oil. Even yoga can be helpful here. All right, so last, I want to get into some patient cases involving hormones and also that new prescription that I was talking about, so you can see all of this in action. So here's the first patient. She is a 50-year-old female who is on an estradiol patch. It's the 0.05 milligram once per week and 100 milligrams of oral progesterone. These hormones have been adequately helping her hot flashes and her night sweats. Her mood is pretty good, but she's still experiencing unwanted facial hair and weight gain in the waist. And so I am just showing you the main actionable findings from the front page of her HUMAP report. And so what we're seeing is she has excess DHEA plus DHEA sulfate. So red means it's above the range. So that's right here. Her 4-hydroxyestrone is outweighing her 2-hydroxyestrone because these are upper range because they're yellow. And then next, her DHT is upper range. You might also notice that some of these are red here. When someone is postmenopausal and they're supplementing estrogen, these levels are going to be higher because they're above the postmenopausal endogenous range. So don't worry about that. But look here. Where'd my mouse go? Look at these ratios for methylation activity. These rectangles are green, meaning the ratio between the methylated estrone and the corresponding hydroxylated estrone is optimal. So methylation looks great on both sides. So that's good news. I think that likely contributing factors for her high DHEA and also that high 4-to-2 ratio could be psychosocial stress and also blood sugar dysregulation. So these are our therapeutic options. Oh, inflammation, I forgot to mention. So I'm going to try to treat the cause. So address the stress. How is she perceiving her stress? Think about how is her diet and lifestyle contributing to insulin resistance and regulating blood sugar and inflammation as well. So EGCG is a component of green tea. It can both downregulate 4-hydroxylation and also 5-alpha reductase. And I'm purposefully choosing supplements that have multiple effects to help her so that we don't have to give her a ton of different supplements. I don't want to waste her money. So the next thing is curcumin. That can decrease 4-hydroxy. It can decrease inflammation. It also decreases formation of DHEA from pregnenolone. And then, of course, lifestyle down here, fiber, adequate protein, healthy fat, resistance training, make sure she's sleeping. All of those things are as important, if not more important than the supplements for her. Okay, so my next case is a longer case. So I'm just going to include 2 cases in this talk. This is a 42-year-old female who had a hysterectomy, and she's been having really significant night sweats and hot flashes, causing terrible insomnia, really bad irritability, and she's having racing heart rate sensation. And she has been put on 2 milligrams of oral estradiol when she arrived at my office. She had started at 1 milligram, and then she gradually increased it because it just wasn't helping her. And she also tried gabapentin for the night sweats. She couldn't sleep. She felt confused, and she didn't like the estrogen patch because she likes to swim, and she found the patch was interacting with her bathing suit. So she didn't she didn't feel comfortable with it. So my first move is to test her salivary estradiol level because I'm kind of worried on how much estrogen she's taking. And so saliva testing represents therapeutic levels of bioidentical hormones and tissue levels. So her estradiol level is 71. That's really concerning to me. The range for supplementation only goes up to 6. I also noticed that her progesterone level is in the postmenopausal range, and it's not balancing out the estrogen very well. I hope this number would be 200, but it's only 0.3 for the PGE2 ratio. And she's got low DHEA. She was talking about trouble building muscle despite adequate workouts, so that's important too. And then her cortisol is taking a dive at noon and beyond. So these yellow represent suboptimal values for all of these. Okay, my plan is to gradually taper down her estradiol in order to get it to a more reasonable level. And we're going to do this gradually to try to minimize any worsening of symptoms, because when you change hormones, when there's hormone fluctuation, you're going to get more vasomotor symptoms. So the first thing we did was decrease the estradiol to 1.5. And then every 3 to 4 weeks, as tolerated, I'm going to bring it down by 0.5 again. We added in some progesterone because I like to use progesterone with estrogen, even if they don't have a uterus. And we're going to start her at 5 milligrams of DHEA. And then I used this adrenal support supplement because I think she needed some support for stress because that was contributing to her irritability. And so when she came back, she was having a little bit better sleep, slightly less night sweats. But then 3 weeks later, things got worse again, and she decided to lower her dose of estradiol herself down to 1 milligram. And this helped. So this made me kind of nervous that she was adjusting her dose herself. I talked with her about it, but at least we were on the same page about trying to decrease it. So the next time I saw her, I decided to try to bring her estradiol down further to 0.5 after a few weeks. She did this, and then her hot flashes got worse. She got hormonal headaches, and she went back to the 1 milligram, and her headaches got better. But she did like the progesterone and felt like it was helping her sleep. So I increased the dosage to 200 milligrams. And since her vasomotor symptoms were not really responding to a good dose of these hormones, I added on this new drug, Veoza, which is also called fezolinetant. It works on the hypothalamus to reduce heat signals. And in studies, it reduced hot flashes by about 60%, which is much more effective than antidepressants. And this worked really well for her, and her sleep was significantly better. For almost the whole night, she was waking up at 4 a.m., which was much better than before. And the other thing is I'm getting her away from the oral estrogen. We talked about this. I wanted to not make too many changes at once. So my first goal was to decrease her dose. And now we're moving on to topical biased. And initially with this change, she had worse headache. But once the Veoza kicked in, then she was feeling much better. And she was still suffering from low libido. So even though her testosterone wasn't overtly low, it was towards the bottom end of the range. I added in testosterone topically for her. She felt much better on this. And eventually I convinced her to do an estradiol patch because she really needed more hormone stability than twice per day cream dosing could provide for her. And so I added that estriol to the testosterone cream because the patches are only available in estradiol and not in biased. So this is her final treatment plan that she's still on today. Eventually, she finally did the saliva test that I gave her, and now her estradiol is in a safe range that we're both happy with. And I haven't heard from her in a while because she is feeling great. So that's the end of this case. It took a lot of adjusting and changing, and I met with her really often, but we finally got her to the doses and delivery methods that worked for her. And that is the end of the presentation. So I'm ready for your questions.